Hi, I am Pat Iyer with Legal Nurse Podcast. Welcome back to the show. We have listeners in 95 countries, and I'm delighted that you have joined us. I would love it if you would send me a picture to my email address at patiyer@legalnursebusiness.com and show me where you're listening to the podcast. I'd love to see your background. Of course, it's got to be a decent background. No bedroom scenes, please. But treadmill, taking a walk, listening by the ocean, I would love to see where you are located. My guest today is Michael Zema, who is an individual who earned his degree at Cornell University Medical College. He is a New Yorker transplanted to other parts of the world who has gotten his education and gotten into the medical legal world through becoming an expert witness. As we were thinking about what would be the focus of the show, he came up with a title called The Expert Medical Witness, Be All That You Can Be, Lessons Learned from My Past. And oh boy, Michael, if we're paying attention, do we ever get lessons when we are working in this world? What sparked your thoughts about that topic?
Well, Pam, having had the occasion to look at some of your previous podcasts and your experts, all of which were very excellent, I noticed that many of them gave literally a treatise on a particular area, whether it be in gastroenterology or other subspecialties of medicine. I thought to myself, my easy way out here is I can just give a little blurb on acute coronary syndromes, on the approach to the patient with chest pain. And I said, there are so many good websites that they can go to today and spend 30 minutes on like up to date things like that nature. I said, so why not be unique? Why not give them? The audience is nurses who do legal case reviews. Let me give them some of my experience. I'm senior here, very senior, let me assure you folks. And so I've walked the walk and talked the talk. And although I'm not a professional expert witness, I'm a professional cardiologist who has been called upon throughout the decades to do expert witness work. I think I've come up with some pearls and some ideas that can help your audience. And that's how I decided to choose the topic.
And we look forward to those. Some of our listeners are in the realm of behind the scenes legal nurse consultants. Some of them are expert witnesses. We have attorneys who are listeners to this podcast. So we look forward to the tips and strategies on maneuvering what can be a challenging world. As I'm sure you have found out, Michael, in being an expert witness and working with attorneys, there can be some tests of your knowledge, of your stamina, of your skills, of your ability to think on your feet. At least that was what I noticed when I spent 25 years testifying in courtrooms.
Absolutely. I can attest to all the things that you mentioned.
I'm sure you can. And Michael, you and I both grew into medicine at a time when medical records were handwritten, papers, things that you kept in clipboards at the nurse's station or in your office. And we've transitioned to electronic medical records for the vast majority of medical records in the United States. I hear complaints about the reams of information. I experience it myself when I open up a medical record and I see thousands of pages that have been supplied to me. If we take a look at that huge amount of information that we get about a patient's care, what are your strategies for cutting through all of that, what can be extraneous but might be important, to get to the heart of a case? What can you tell us about that process?
Pat, you're right. My vintage is I came from paper. And in fact, in the first chapter of my book entitled The Electronic Health Record, the good, the bad, and the ugly, uh, I allude to many of the things that you've mentioned. I still have a fondness for paper. When I read a book, I much rather read it, a book that I can hold, than a digital copy. I used to like reviewing paper because I could mark it up. I could put a check mark in the pages that I thought were really relevant. I could set them aside. It was so much easier. And there was less redundancy because, of course, there wasn't the copy and paste, which we'll talk about a little later. So, now that I'm getting digital records to review, how do I deal with this? Well, I start with coffee, then I go to hot cocoa, and then I go to espresso. It is really, really hard to stay awake and go through pages and pages and pages of CRT digital records. It can be boring. Get up, walk around, do 20 jumping jacks, come back again. So what I've tried to do is make it an educational experience. So I take a break. If I've come across something that I say, maybe there's a chink in the armor here in this case, let me spin off for an hour of my time and let me go online. Let me go back to a few of the textbooks and let me see what I can find. I don't necessarily charge my clients for that time because it's a teaching tool for me and it breaks the boredom. I'm up to page, 9,727. I take a break at that point in time. So let me use a case. And again, we're not going to discuss the whole case, just a little snippet that deals with the boredom of reviewing cases. Let's look at a case of a post-op ileus. It was really a post-op ileus, misdiagnosed as just pure opioid nausea. It's a 375-pound super obese male recovering from orthopedic surgery. And the notes say that they're trying to defend, of course, that this was not an ileus. So the notes say, well, he didn't show signs of ileus. He was not distended. Now, at 5'10" and 375, Pat, I have never met a human being that walks on the face of the earth that is not distended. What is the surgical definition of distended for your audience? If you draw a line from the xiphoid process to the pubic symphysis, okay, it depends upon where the umbilicus lies. Above that line, on that line, or below that line. If it's below that line, you've got a scaphoid abdomen. If it's on that line or nearly on that line, you've got a flat abdomen. If the umbilicus is above that line, then you're distended by a surgeon's definition. At 375, 5'10", he's distended normally. So tell me he's not distended and you're lying. Okay. Now, if you mean he's not tense, he's not tympanitic on percussion, then you better put that in your note. But it was not there. In that case, also, they argue that, again, there was no signs of ileus because the patient had bowel sounds. I'm a cardiologist. I said, bowel sounds, we're all taught that in medical school. Examine all 4 quadrants, spend X number of seconds with your stethoscope in each quadrant. I said, how reliable is that? Well, let's go online here. Let's make this a little interesting. Bowel sounds are very interesting. Okay, most originate in the stomach, next most the colon, and least the small intestine. And how reliable are they to diagnose or help diagnose an adynamic or paralytic ileus? Well, they're not. The presence of bowel sounds is unreliable for diagnosing, or for ruling out an ileus. The absence of bowel sounds with a good exam, 30 to 60 seconds, is consistent and has fairly good specificity for an adynamic ileus, although it lacks sensitivity in that regard. In other words, the majority of cases with at least a partial adynamic ileus have vowel sounds. So I said, that argument, I found another chink in the armor there. Do they talk about whether the gentleman passed flatus? No, that's a little more reliable. Although there's one paper in the literature that I could find on the reliability of flatus, okay, to rule out an adynamic ileus. Did you pass a stool? That's the reliable. Did you pass a stool? And you probably are not having an adynamic ileus. So that little sidetrack that took me, an hour on my own, I said, well, I learned something and I found a few chinks in the armor on this case. Now, again, standard of care, okay, but standard of care, as you know, is half the argument. Causation is the other argument where I spend most of my time when I review cases. So that's an example of what I'm talking about. Break the boredom, because it is boring. It is not what nurses and doctors are trained to do. Look on page after page after page of digital records.
Well, and part of that, Michael, I think, is because there's so much volume of content that is created every day by the repetitive copying and pasting the same fields that come out over and over again. If the nurse makes one change, it may spit out the same 20 pages, but just have that one data point that is different. I know you mentioned a few minutes ago copying and pasting, and that is particularly something that you have experience with and opinions on, and I'd love to know what you think about copying and pasting. Is it helpful? Is it the bane of our existence? What's the deal? Before we continue with the show, I'd like to share this special announcement with you. Here's a quick video about telling stories in your blog posts. Not only do stories help pull your readers into your writing, but these stories also help make your points and concepts more memorable. What kind of story should you tell? Just about anything is relevant. Here are some examples from Blogging for Legal Nurse Consultants. Share your knowledge and attract clients. Consider telling a story about yourself. For example, if you're writing about how you helped an attorney understand a key point in a case, telling a story about yourself makes you real and approachable to your readers. This enhances the know, like, and trust element. Tell relevant stories about somebody else. You could tell a story about a client who benefited from your services and got great results. This deepens your credibility. Tell well-known stories. These could be fables or stories about historical events or even stories that you pull from well-known books and movies. Make sure you're accurately recounting the details. If you flub them, there's a chance the reader will realize you're being inaccurate. One of Aesop's fables tells of two goats who met in the middle of a narrow bridge. They couldn't pass each other, neither would yield. They locked horns in battle and fell off the bridge to be swept away by the river below. Aesop's moral is that it's better to yield than to resist stubbornly and be destroyed. You can apply this principle to many professional and personal situations. You'll find many more valuable suggestions in Blogging for Legal Nurse Consultants. Share your knowledge and attract clients. Get it today at lnc.tips/creating series. Now let's return to the show.
Well, copy and paste again, the good, the bad, and the ugly. Not much good, I'm afraid. Just not much good that I can say about it. And how about the bad? The bad is obvious. Error propagation. If there's an error in the record, And over and over and over, it's carried through. Another example, I'm working at Kaiser Permanente, which, by the way, is an excellent place to work, at least in Moanalua, Hawaii, where I was working at the time. Very well-run clinic, excellent medical assistants, using Epic as their EHR long before it was ever used big time in this country, or rather in the mainland. And I'm seeing a new patient in clinic, and I'm reading the history before the patient enters the exam room. And this is a gentleman who had a bypass surgery, yada, 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 yada. Okay, so in walks Mr. Smith. Introduce myself. We have a little friendly chat. And I say, how have you been since your bypass? He looks at me. He said, you got the right patient, Doc? I said, is your name Joe Smith, date of birth, yada, yada? Yes, sir. I said, I'm looking at your medical record, Joe, and that's what it says here. And of course, when I examined him, there was no median sternotomy scar. And this was long before, we had, minimal invasive cardiac surgery. So then I went back after he left that day. I said, let me go back. How far does this era go? That era was propagated for over 2 years in this gentleman's record. Now, obviously, he had been seen in the last 2 years, but nobody took the time to go into that record and change it and correct it. That's another one of my pet peeves that you can read about in my book. The 10-minute exam. And how many patients can you see per hour, doctor, when you're hired? Right? So, just bring on the next patient. They're waiting for you, doctor. So that's part of the problem. That maybe is the bad. Also in the bad is copy and paste removes a very important step. What is that step? That's the step where you review in your mind and you synthesize the case. To synthesize the case, you have to truly understand what's going on. Copy and paste eliminates that. You just hit a button. You don't really have to think about what you're saying in that paragraph. In fact, maybe you don't even review necessarily what's in that paragraph. So that takes away the synthetic function, which is so important when you put together a case in your mind. And lastly, the ugly. Remember I said, no good, here's some bad, how about the ugly? The ugly is the use, Pat, the use can have a somewhat, I'll use the word pernicious, a somewhat pernicious, what we call the illusory truth effect. The illusory truth effect. That's a glitch in the human psyche that equates repetition with truth. If you hear something said enough, it becomes the truth. And that's something that all of our psyches are linked into. It is very difficult for us to take that and set it aside and negate its effect. And so that's a real ugly thing. Because if we start changing what is true, and that's not just in medical records, that could be in politics, that could be in anything, in finance, something said often and often enough, or repeated on a screen often and often enough, becomes the truth. Another case in point, Stevens-Johnson syndrome that I was asked to review. Patient presented to the emergency room with symptoms of an upper respiratory tract infection. Looked like a URI to the examining doctor. The nurse, to her credit, and I caught this in her exam of the mouth, said, I believe there's white patches in the mouth here. And that was the beginning of mucus involvement of Stevens-Johnson. But the doctor, empirically gave some levaquin and drew the appropriate cultures, discontinued the levaquin on follow-up a couple of days later. By that time, the patient was starting to get worse with the Stevens-Johnson. And of course, the one of the attorneys for the plaintiff argued that it was Stevens-Johnson's from the Levaquin, which should never have been given empirically like this, and that deviated from the standard of care, which I can argue really did not. But the bottom line is, if you go further on in the case, when they transferred that patient to a tertiary care center, as the skin started to break down, the doctors there kept stating the same thing because they had read it in his note, and the intern read it, and the resident read it, but the infectious disease person read it and switched antibiotics to what? To what? To another fluoroquinolone. To another fluoroquinolone. And I said to my attorney, I said, bingo, there's your answer that nobody believes it was due to Levaquin, because it's absolutely contraindicated for them to have changed to another fluoroquinolone if they thought the Stevens-Johnson was from Levaquin. It was obviously from the patient's lamotrigine, Lamictal, that she had taken in weeks prior to that emergency room visit. But again, if it's in the note over and over and over again, it actually can become the plaintiff's complaint. What the plaintiff was alleging was gotten into their brain, if you will, by this illusory truth effect. Something we have to be very careful about.
Yes. Yes. And that's a very nasty syndrome. I've worked on a couple of Stevens-Johnson's cases where the skin sloughing was intense. I know that that you have a special interest because of your training and board certification in the area of pharmacology, combining pharmacology and cardiology, which is not a real common combination in this country to have both board certifications. Tell us about how that interplays when you're evaluating a case as an expert and you're looking at it from that dual lens of the cardiology piece and also the medication piece.
Yeah, I think I took the first set of clinical pharmacology boards that was offered by the American Board of Clinical Pharmacology back in the early 90s. Bill Frischman, of course, everyone knows Bill. I mean, in cardiac pharmacology, he's probably got hundreds of publications. Bill and I sat for the first exam, and we were in the classroom down in Georgetown taking the exam. Bill looked at me, and I knew him, and he knew me. And I said, Bill, why are we here? This is full of PhDs, this room. They're all playing with their slide rules. And I said, what are two MD cardiologists doing here? But I never regret that, because the insight that I had gotten from that, learning that discipline, and it wasn't just cardiac pharmacology, it was Goodman and Gilman. It was the real deal, all drugs, all categories. It's allowed me to have an insight into cases that I don't think the average reviewer has. And indeed, most of the cases that I've gotten have not been pure cardiology. They've been cardiac pharmacology. If you look at malpractice actions, and the literature is somewhat divided on this, but most experts would agree about 5% of the cases are pure drug related. If you want to call them medication errors, I don't like that term. But another 25%, of course, which are related to treatment problems as opposed to diagnostic errors. Most of those treatment problems get yourself back to drugs again, medications that are used either inappropriately, wrong dose, wrong drug, not compounded properly. We can go on and on, but there's a million ways that you can get to the medication aspect of it, and that's been my bread and butter in the expert witness domain.
Did you say 300 people in the country?
There are about 300 MDs who have that certification. There clearly PharmDs and PhDs who do have it. They do have a nice annual meeting, and they have some other meetings throughout the year. It's a very interesting group of individuals, and I would hope that more of our medical doctors attempt to get that certification.
Another question I had for you, probably my next to my last question, is you review cases for both the plaintiff attorney and the defense attorney. Is there a difference in the way that you look at a case depending upon which side has hired you?
I think they actually have more similarities than differences. In fact, sometimes when I review a case, I get into it enough, I wonder which side I'm reviewing for. I review the facts and I let them take me where they will. Sometimes that's to the pleasure of the attorney that I'm working for, and sometimes it's not, but I feel it is my duty to tell that attorney in those cases where it's not pleasurable what he or she may be hearing from me. I constantly attempt in my review to think like the opposing counsel and his or her medical witnesses. How are they going to attempt to establish or debunk, as the case may be, causality? Are there medical guidelines, even sometimes if promulgated outside the US, which I've used on occasion, which may act as some sort of safe harbor for a defense? And again, I'll tell your audience, whether it's in medication or not, be sure that you're using guidelines or appropriateness criteria that are contemporaneous with the case that you are reviewing. I reviewed a number of QT prolongation, sudden death cases where the plaintiff's witness said, this drug is black box, blah 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 blah, should not have been used with X, Y, and Z drug. And I said, that's very, very nice, but this case occurred, in the year 2007, and that black box came out in 2009. We can't know what's not been published. So keep that in mind. And sometimes it's difficult to go back and get that information. Now, things don't stay on the internet forever in the scientific realm. And so, again, because of my contacts, if you will, in pharmacology, sometimes I can dig that information out. What were the guidelines for X, Y, and Z in 2005? Not easy to obtain, but obtainable with a lot of effort. So make sure that whatever guideline you use, it's contemporaneous with the case that you're reviewing.
Do you have one final tip for our listener related to functioning in the world of being expert witnesses?
One, huh?
Just one. That's all we have time for.
Give me that question again, Pat.
One final tip that would help us function in the world as expert witnesses.
Never forget who you are. You're a nurse first. You're a physician first. That's your training. The lawyer who may be cross-examining you, that's not his or her training. The lawyer, I'm going to take a moment here on this. The lawyer is trained to take you to a destination. He or she will do that with a series of questions requiring yes, no answers. And only he or she knows where their final endpoint is. That's not your training. Your training is science. Science is very little yes and no. It's a lot of maybe and shades of gray as opposed to black and white. So if you're on that witness stand, try to use your best guess. Where is that attorney taking me? Because if he takes me far enough down that trail, I won't be able to do much to turn that around backwards again. So if you can spot where this is going, then sometimes you can use this technique. Sometimes you can say, counsel, I can't answer that. What do you mean you can't answer that? Well, it doesn't have a yes or no answer. That's the question, doctor. Yes or no? And then you can turn around and say, If it please the court, I would just like a moment to explain why this is a qualified yes. Now, you may be able to do that once in a hearing. You're not going to be able to do that 4 or 5 times. You're going to be, subject to contempt. But you can do it once, and if you do it at the appropriate time, you can turn that chain of events that the attorney is putting in front of you. You can turn it around a little bit on himself, and that can sometimes have an effect upon the outcome of the trial.
Yes, that's a great point, Michael, because it's thinking on your feet, trying to anticipate where the attorney is going, trying to craft the answers in a way that will drive home the points that you want to make, sliding in those whenever possible, being very aware of not hesitating too long in answering a question, of keeping a very respectful tone, not getting irritated and agitated with the attorney who's cross-examining you in the courtroom. All of those experiences I have learned from the hard experience of being on the witness chair, as you have. It is, in some ways, I think the most challenging aspect of being an expert is handling the cross-examination well, so that you can do as much for your client as possible without stepping across lines.
Very well put, Pat. Very well put.
Now, I know that our listener is going to want to know how to get in touch with you to ask more about your services. What would be the best way for that to happen?
Well, a number of ways. I don't do a lot of social networking. LinkedIn is my site. Got about 6,000 followers there. So you can certainly reach out and connect with me on LinkedIn. If we have things that we can do business with together, and I will give more contact information through LinkedIn. I'm loath to give out my email address except through LinkedIn. So I use LinkedIn as my first barrier, if you will. But I will take a moment to put a plug in for my book, because my book does cover some of the things that we've talked about today, and that is modern healthcare delivery, deliverance or debacle, a glimpse from the inside out. You can find that on Amazon, Barnes & Noble, Google Play, Apple Books, in digital or print format.
All right. And just to be sure that you know Michael's last name, it is Zema, Dr. Michael Zema. And the book again is Modern Healthcare Delivery, Deliverance or Debacle, A Glimpse from the Inside Out. Definitely a book to have on your reading list. Thank you so much, Dr. Zema. I have a feeling we could have talked for another 3 hours and swapped war stories and shared some of the special insights that you get when you work inside the medical legal world, the way that it changes your perspective on even simple things like going to the pharmacy to pick up a prescription to make sure that, oh, what's in that pill bottle is really intended for me or not for another person with my last name, for example, as happened to me on one occasion when I went to the pharmacy to pick up a medication that, that's not for me. I don't know what this one is, but not one I'm planning to take. Lots of opportunities in our healthcare system for us to do things right, and many opportunities for us to do things wrong.
Yes. And the public is very unforgiving, unfortunately.
I appreciate you being a guest on our show. I appreciate you, the listener, who has been listening to us chat about some cardiology cases, some aspects of being expert witnesses, some of the challenges that we experience. I would appreciate it if you could give us a thumbs up or a thumbs down on the YouTube channel, Legal Nurse Business, where you'll find the video version of this podcast, and come back next week for a new show, new topic, new guest. Thanks so much. This is Pat Iyer with Legal Nurse Podcast. Coming up next, we are taking you behind the closed door, behind the curtains, into the PACU with our next guest, Pat Hirsch. She is clinically working, clinically active and shared with me in her show some of the hot topics, high-risk aspects of working in a recovery room, post-anesthesia care unit, or PACU. Pat, what were some of the topics that we covered in your show?
We talked about liability issues in the PACU with a focus on patient falls. We talked about risk factors of falls and ways to identify patients who are high risk for falls. We talked about airway disruption, how to assess patients, and treatments for problems with airway problems, and also bleeding in the PACU, how to identify signs and symptoms of bleeding and what intervention is. And also we talked about crisis nightmares in the PACU, things that can go wrong, that have gone wrong, and things that scare you.
And if you hadn't considered some of these clinical crises before, by the time you finish watching Pat's podcast, it will give you a greater appreciation for the risks and the challenges of working in this critical care environment. Be sure to come back and watch Pat Hirsch's podcast on PACU challenges. Thanks so much.